Hi, my name is Luke To, and I'm going to be sharing with you today about uterine artery or uterine fibroid embolization. Whether is it suitable for you? Since this is a College of Radiologists event, I'd just like to share a little bit about diagnostic radiology. Diagnostic radiologists are people who actually use various imaging modalities, including X-rays, ultrasound, CT scans, MR scans, nuclear medicine scans to make diagnosis based on the imaging findings. And interventional radiologists are people like me who spend further years training to use these imaging modalities to perform procedures using various catheters, wires, and needles to get the job done. Yes, interventional radiologists are real doctors. So, like surgeons, physicians who spend years in medical school, so do we. Back to the topic of the day, we're talking about symptomatic fibroids. This can be pretty insidious in terms of presentation because menorrhagia can worsen gradually over time. But if you do find that you have requirements to change your pads very frequently, you have flooding that's not contained by the pads, require long-term iron therapy because you're always chronically tired, you pass out clots that are more than 50 centimeters in size, or you have had blood transfusions in the past because of heavy menses, these are signs that you're actually having very bad menorrhagia. Mass effect can take the form of urinary frequency, change in bowel habits and constipation, poor appetite because of the large mass effect that the fibroid actually takes up in the abdomen, and therefore there's not much more space for food. You may also have painful intercourse. Now, this image at the bottom right corner, we find this. So we see this X-ray machine that is capable of taking live X-rays for long durations of time. This enables us to actually inject dye into the blood vessels and see how the dye flows. This would then be able to guide us uh, to get into the vessel that we want to and to block off the vessels that we need to in uterine fibroid embolization. It is therefore a very minimally invasive non-surgical procedure that is done through a tiny access in the skin, usually through the groin, but increasingly more practitioners are coming from the wrist. We use real-time imaging, like I said earlier, to see how the blood vessels flow. So these are static images of the right uterine artery. You can see how squiggly it is, and it becomes so very loopy. And these tiny vessels that branch off from the ends of it are the arteries to the fibroid. These are the so-called tumoral vessels. Same thing on the left side, you can see the uterine artery coming out, and then it branches into smaller branches. But you can see that there are some very closely packed branches where the main feeders to the uterine fibroids are. The catheters that we use are generally less than 2 millimeters in diameter. And so these catheters are advanced into the uterine arteries under the X-ray guidance, where we then release tiny particles that are the size of grains of fine sand to block the blood flow that supplies oxygen and nutrients to the fibroids. And over time, the fibroids will shrink and disappear. Generally, the duration of the procedure is between 60 minutes and 120 minutes. You can watch this short video for a better appreciation of what uterine fibroid embolization is.
To gain access to the femoral artery, a long flexible tube called a catheter is then inserted into the femoral artery. It is guided up the femoral artery and into the artery that supplies blood to the uterus, called the uterine artery. The catheter is then guided to smaller arteries that supply blood to the fibroids. Uterine fibroid embolization delivers tiny microspheres to the artery that supplies the fibroids, cutting off the blood flow, causing the fibroids to shrink. The tiny microspheres are injected through the catheter and travel through the blood vessel. Since the microspheres are more than 60 times larger than red blood cells, they plug the tiny vessels that red blood cells travel through to feed the fibroid. The procedure is repeated in the uterine artery on the other side to make sure that all blood supply to the fibroids has been cut off. All fibroids are treated simultaneously. Once the blood supply to the fibroids has been blocked, the fibroids begin to shrink. There is no scar tissue and minimal blood loss with UFE. Recurrence of the fibroids with uterine fibroid embolization is rare. Most women are able to return to light activity within a few days of the to gain.
And so, therefore, uterine fibroid embolization is an established alternative to surgical management of uterine fibroids. Of course, certainly is in selected cases. The procedure involves blocking off of the arterial supply to the uterus using tiny particles. These are microparticles in the range of 10 to the power of minus 6 in size. The result is reduced blood flow, reduced nutrient supply, and therefore starvation of the uterus. And while this may be a dated article, it was from 2004 from CNN, the then incoming Secretary of State, Condoleezza Rice, actually had uterine fibroids, which are very common in the Black community. She had this procedure done by Dr. James Spees, and it took about 90 minutes for it to be done. And upon completion, she stayed on in hospital overnight, went home the next day, and was back home on the following Monday. Now, what do we expect after uterine artery embolization? Immediately, you will have crampy pains. That is the worst during the first 12 to 18 hours. This will improve to a pain score of 2 to 3 out of 10 by the next morning. And you need to continue on the oral painkillers. I would usually recommend it for a week. The initial day of hospitalization after the procedure is to allow us to titrate the pain medication rather than to send you home with a bag of medications to suffer in silence. You'll be given usually 1 week of hospitalization leave for this procedure. Now, the crampy pains actually would improve or stabilize over the first couple of days, sometimes weeks. Most of my patients actually stop taking the painkillers after 3 to 4 days. And most of them also get back to their regular activities after 7 to 10 days. Most patients actually head back to work after a week and back to their usual exercise regimen within 2 weeks. From my experience, the sooner patients get back to their physical exercise regime, the better their recovery and the sense of wellness comes back sooner. You do expect to also have persistent low-grade temperature over a period of time. Now, the expected positive outcomes are that the fibroids would shrink, and then you'll also have normalization or at least reduction in the menses after the first 1 or 2 cycles. There'll also be reduced menstrual cramps. You should also have improvement to the urinary and bowel symptoms as the fibroids shrink. The residual fibroid after shrinkage is expected to still be between 50 to 60% of the original size. That's probably at least 6 to 12 months after the embolization. However, if you do actually pass out the fibroid, then of course you expect a bigger shrinkage of the fibroid from the original size. I'd like to illustrate with a case. So this is a patient. On the leftmost image, you see that it is a post contrast enhanced scan where everything lights up. So this shows that the fibroids are viable, as in alive. In the middle image, you can see this black part that represents one of the fibroids. And over up here is another black part that represents the other fibroid. And the image on the right is 1 year after embolization, where you can hardly see any trace of any fibroid that's left behind. And also, the entire uterus has shrunk back down to a very much more normal size. This is another patient with a large subserosal fibroid. The subserosal wall refers to the inner wall of the uh, uterus, which is so this is another patient with a subserosal fibroid. The subserosal wall is the wall that is in the abdomen rather than at the lumen or the endometrial wall of the uterus. And so after the embolization, this particular patient had a lot of discharge, mucus discharge of the dead fibroid. And a year later, you can see that the fibroid has actually shrunk down very drastically. Corresponding angiographic images showing the right and the left uterine arteries, you can see that in this particular case, the fibroid was predominantly supplied by the left uterine artery with some supply from the right, as you can see from these tiny gray squiggly branches. Another patient with giant fibroid, this lady had a large, almost 13 centimeter fibroid that extends all the way up to the mid lumbar spine level. And you can see that actually there's a little wall that separates both halves of the fibroids. So these are two separate fibroids. And this was the anatomy, the vascular anatomy that shows how the vessels flow and how all the tumoral vessels are actually very large on the right side as well as on the left side. 9 weeks after embolization, the patient actually had cramps, and following initial passage of mucus discharge for a couple of days, she actually first passed out one chunk of fibroid that measures about almost 10 centimeters, and then 5 days later, she passed out the other half of the fibroid. Now, after embolization, we will review you in 1 week's time to make sure that everything's under control. At 3 months, and 6 months, we would be performing an ultrasound scan to compare and see how much shrinkage there is. At 1 year, we would do an MR scan to compare with the pre-embolization MR scan to see how much shrinkage we have achieved. And again, we will still follow up you at 18 and 24 months to make sure that the fibroid continues to shrink or doesn't regrow. Now, so is embolization suitable for you? Well, if you have these symptoms, heavy menses with anemia, severe cramps, mass effects causing pressure-related issues, tummy swelling, then certainly it is worthwhile considering because fibroid embolization reduces the menstrual flow, reduces the mass effect, but this would come at a cost where you have dead fibroid coming out as mucus discharge. You may have cramps for a period of time. You may also have low-grade temperature as the dead cells are releasing the inflammatory mediators into your circulatory system. And you may also have passage of chunks of dead fibroid. If you do not have passage of fibroids and there's gradual shrinkage of the fibroids, the residual dead fibroid becomes calcified in your body over time, and it does not have any cancer potential. Now, is embolization suitable for you? Well, so long as you're aware of some of the side effects or potential issues, including cramps, vaginal discharge, possibility of infection if the dead tissue remains in your body and is not passed out, that you may pass out solid clumps of fibroids, which is similar to childbirth to some people in experience. So long as you're mentally prepared that you may need to have a repeat embolization if there's a procedural failure or recurrence of the fibroids or even surgery when there's a need, then it is something that you really can consider. Whatever the case may be, we work closely with your primary care physician, your GPs, and your obstetrician gynecologist to come up with the best management plan for you. This is not a unilateral decision, but something that needs to be discussed because every patient's needs are different. So not all women are candidates for uterine fibroid embolization, and similarly, not all women are ideal candidates for surgery. Undergoing fibroid embolization does not mean that you cannot have surgery later on if you need it. So keep calm and call the interventional radiologist. Thank you for your attention.